So thank you for the kind introduction, Jason Seni and Sung-Hae Seni. It's very great pleasure to present again in this great session. So I have to say that large PDA to begin with is not only technically challenging for transcatheter closure, but can also lead to challenges in the indication for closure and circulatory management, depending on the degree of pulmonary hypertension. I'm going to present such experiences in infancy. Implanted devices were introduced in Japan more than a decade after their introduction in the United States. ADO2 was introduced in January 2019, and Piccolo was introduced in Japan in April 2020. It was exceptionally early introduction for us, of less than a year after extremely favorable clinical results in the United States. Therefore, we currently have ADO2 and Piccolo occluders, both of which have double retention discs and are particularly advantageous for small patients. Let me show you two cases in this presentation. The first one was a critically ill baby. She had been managed in the other NICU until she was 8 months old and referred to our hospital. With right lung hyperplasia and secondary ASD and chronic lung disease and severe pulmonary hypertension, her body weight was 3.6 kilo at that moment. We planned the PDA closure and subsequent tracheostomy for her. Her PDA was type C with minimal diameter of 4.6 millimeter. QPQS was measured as 0.9 at the thick sampling and very unstable, and she also had ASD and good reaction into inhaled nitric oxide. And she was indicated for repair and treat strategy. Initially, we deployed a 4/6 ADO2, but with a closer look, you can see the 10 millimeter retention disc of aortic side were completely drawn into PDA, and the PSI disc was also slightly pulled into PDA. Therefore, we changed the device into 6/6, the biggest one, in order to fix the discs at both ends. In significant pulmonary hypertension cases, you should stabilize the device by pinching the double discs from both sides. And in this particular case, we thought that she was not able to tolerate the device retrieval process or open heart surgery, so we must avoid embolization at any rate. She transferred back to the local NICU 10 days after the procedure. The second case appeared on the last Christmas Eve. He was 31 weeks and 5 days gestation with a birth weight of 1.6, and he had Down syndrome with a persistent pulmonary hypertension of the newborn. One course of ibuprofen and 2 courses of indomethacin did not narrow the duct at all. The chest X-ray appeared like this. The echo showed a PDA, and PEA end measured 2.4 millimeter with a bidirectional shunt, a flat ventricular septum, and a left-to-right shunt at the atrial level. At the age of 15 days and 1.7 kilo, we decided to bring him to our cath lab. When we performed Piccolo procedure at a premature baby, we cut a narrow U shape in the center of the head side of the drape like this and cover it with a transparent dressing tape. Preparing for visualization of the patient's head and trunk skin color and enabling quick TTE check from the drape field. The combination of a 4 French glide cath and a 0.035-inch Asahi Intec silverwire wire crossed the PDA very smoothly with clockwise rotation while advancing the RVOT. While pulling back the cath from the aorta to pulmonary artery with 0.5 cc of dye, we visualized the entire PDA. Unlike the evaluation by echo, we measured the PDA as 4.2 millimeter at the PA level, at the 5.1 millimeter at the aortic end, and 8.4 millimeter in length. That was huge type C. Immediately after the contrast, his saturation dropped markedly with when we considered the pH crisis, and we treated him with inhaled nitric oxide and increased inotropes. This is a peak coinciding chart provided by Dr. Xiang from Memphis, which you will also use. It is known that more than 90% of low birth weight infants weighing less than 2 kilos receive a size of 4-2 piccolo. And based on the finding of the overall finding of 2 to 3 millimeter in diameter on echo of our patient, we expected the size to be around that same level. However, the actual diameter on the angio was more than 4 millimeter. I was concerned that even the largest 5-2 piccolo might not be stable inside the PDA. Using the nasogastric tube and PI catheter placed from the upper extremity to the SVC as landmarks, we deployed a 5-2 piccolo inside the PDA. We observed the Pacman sign and released the device with good fixation. At this time, we intentionally exposed the soft distal end of the delivery cable from the tip of the catheter and applied a very slight pushing force toward the aortic side to prevent it from dropping out toward the PA side. The next day, the position remained perfect and with no leak, and shunt between the ASD was reduced. Subsequent progress has been favorable. Okay. In summary, we should select a double disc device for a large PDA with severe pH because of the risk of the embolization on either side of the aortic side or the PA side. Transcatheter closure is better option for severe pulmonary hypertension in infancy with the expectation of its irreversibility. Thank you.
Thank you, Sung-Hae, for your great presentation. Any question or comment on the case? I would like to ask Ming-Tai that because Taiwan is one of the leading country for the transcatheter closure of PDA in premature babies. So Ming-Tai Lee, please.
Thank you, Dr. Kim, your nice presentation. I have a question about case 1. For the case 1, did you follow up by echography? Is there any LPA stenosis or diminished LPA flow?
Thank you for the great question. We observed no stenosis in the pulmonary artery branches and the aortic side. We observed a leak for a short while. So we were very happy that we had not immediately completely closure of the shunt, but gradual closure. I think that can avoid the pH crisis. But several days after the closure, the shunt is also completely diminished.
Yeah, because from the angio you demonstrated, I guess the piccolo occurred, you use 4x6, right?
Yes.
The length could be a little bit longer, so I guess the PSI disc may be protrude a little bit to the PA. So that's why I am wondering.
Yes, I think so too. I agree with Dr. Lin. Mm-hmm. Yes. So 6, the biggest ADO2 has a 12 diameter discs. Okay. So I think it can protrude, especially in the pulmonary artery, but pulmonary arteries are also already enlarged. And if the patient had branch stenosis, but it may be acceptable rather than the pulmonary hypertension exists.
Okay, thank you.
So Sung-Hae, in the many years ago, we had many times of ADO2 conferences. At the conferences, yes, everybody was saying that we can live without that device. So many complications from the ADO2, and nowadays we seldomly use the ADO2, but you use that device because you didn't have a piccolo or any other the appropriate device at the moment, or you intentionally selected the ADO2 at that time?
At that moment, we had Piccolo very newly released, but the PDA, the first case is a very so big, very large. It's not good for the Piccolo. But we also had AVP2, but in this particular patient, weighing 3.6 kilo, the delivery system should be more low profile, so we selected the ADO2.
Yeah, also the muscular VSD device, small size of muscular device,
Yes.
may require the larger the delivery system, and also I have seen that some doctors are using AVP1, which is not available anymore at the moment. In case the Piccolo or previously ADO2AS couldn't accommodate in the doctors. So I think that case was really well done, but it may be very difficult to achieve such a good result. So yeah, thank you for your case.